Hello and good afternoon, everyone. It is that time. We're going to get started with today's free webinar. And right off the bat, I should probably introduce myself. My name is actually Elizabeth Diger. I just noticed right before the lecture started, we have Jennifer Bonner's name in. She is also another wonderful tutor with Archer. She also does this presentation, and you do get to interact with Jennifer. She is in the chat today. So you get two women's health experts today helping you with labor and delivery. And as you can see, we're talking about labor and delivery. Our presentation today is called Birth Brilliance, Mastering Labor and Delivery. And we're really going to go over the basics of labor and delivery today. We're going to break it down. But to introduce myself, like I said, my name is Elizabeth Diger. I'm a women's health nurse practitioner. I actually spent about a decade in OBGYN. Prior to that, I was really more of a critical care nurse. And of course, now I'm a teacher with Archer. I've been here for about 2.5 years, and I absolutely love it. So let's go ahead and get started. And just so you know, we are going to be using a little bit of Slido today, which is always fun. You can join at slido.com using the hashtag ARLND, or you can scan this QR code in the upper left-hand corner. But before we get started with the actual content, I have to know, where are you guys joining us from? All over. Is that Madison, Wisconsin? That's originally where I'm from. How cool. United Kingdom, all over the US, the Philippines. I'm seeing people in the chat. And by the way, feel free to use the chat liberally today. I'm going to be probably asking you random questions. I'm going to be picking your brain. Feel free to respond to me in the chat. That being said, if you have a question that you need answered, remember, we have the wonderful Jennifer Bonner in the chat. She's going to be answering your questions actually in the Q&A section. So if you have a question for her, make sure you put it there. But Jennifer, like I said, she's also a women's health expert. She's a midwife. Very, very cool role. All right. LA, go Dodgers. Nice. Jamaica. We have people from all over the world, and that's why I love doing these presentations. It really brings us all together. So let's go ahead and get started with the actual content. So to start, we're going to be talking about the birthing options. And a lot of people think, okay, if you're going to have a baby, you have to go to the hospital. Well, that's not actually true. There's a couple different options. There's home delivery, birthing centers, and then of course there's the classic hospital setting, and they really all have their pros and cons. One option is not perfect for everyone. That's why we have a variety of different options. And what I'm going to do first is really talk through what are the pros and cons for each of these birthing options. And as you can see, we're going to start out with home delivery. And there are a lot of pros with that. It gives you greater control over the experience. Of course, you're in a very familiar setting. And if you're someone who knows you want to proceed with a vaginal delivery, well, that's really the only option if you're at a home setting. So certainly it's a good reason to use it as well. Also, because it's in the home setting, there are going to be much fewer medical interventions if that's your preference. There's going to be more support. Typically, you're going to be working one-on-one with a midwife, so you get that very individualized care. You get more time with baby. There's going to be less time taking baby away for assessments. It's cheaper if you're paying out of pocket. Insurance, so probably won't be covered. And then finally, religious and cultural beliefs are often much easier to follow in the home setting. That being said, I do want you guys to be very aware of the cons with a birthing setting in the home. It's not to say that I don't think you should do it, but you really have to know the risks. So really the big issue is it is less safe for both the mother and baby, especially if there's underlying risk factors. If you're considered a high risk pregnancy, like if you have placenta previa or preeclampsia, you should not deliver in the home setting. And what we know is if an emergency happens, you're not going to be able to stay in the home setting. It's very likely you're going to need an emergent transfer to the hospital. And actually, a really excellent provider once told me that you really don't know if a pregnancy is low risk until the baby is safely delivered and in the mother's arms. Things change rapidly during labor and delivery. And if an emergency happens, again, you're going to need to race to the hospital. And by the time you get there, someone might not be savable. So it's something to really consider. The other things to consider is, like I said, it's cheaper if you're paying out of pocket, but insurance usually doesn't cover this. So you can't rely on insurance. And finally, you got to have a plan for where you're going to deliver in the home, because it can definitely be messy as well. Now, if you know you don't want to deliver in the hospital setting, there is kind of an in-between option between the home and the hospital setting, and that's going to be a birthing center. Really a good option, especially for women who want unmedicated, low intervention births. Really, the room is built to feel like a home setting, so it's going to be a lot more relaxed. You can do water births. Those are actually encouraged. The center is going to deal with the cleanup. That's very nice. And often it's going to give you somewhat more personalized care. Again, you're going to be one-on-one with a midwife. But again, there are some cons you have to be aware of. First of all, you don't stay there very long. You typically are going to stay there for about 6 hours after birth, and then you're going to head on home. So if you have a complication after that 6 hours, you're no longer under that safety net of the hospital setting. Also, if you change your mind and want medications, it's not going to be an option. They don't provide those there. They also don't usually provide food or meals. They do not have lactation consultants. So if you know you're someone who wants to breastfeed and you kind of struggle with that, you might want to consider switching to the hospital setting. Again, insurance sometimes covers it, but often does not. And then again, if a true emergency happens, a birthing center can't handle that. They don't have an operating room. So again, if an emergency happens, it's very, very possible that you're going to have to emergently be sent to the hospital anyways. And that, of course, brings us to the hospital setting. Now, real quick, guys, if you have your hand raised, I'm not going to be able to call on you. We have too many people today. So don't use the raise hand option. Communicate to me in the chat, or you can ask questions in the Q&A as well. But the hospital setting, like I said, there are actually some pretty big pros with the hospital setting. And really the big one is if an emergency happens, you have the staff on site. You have the equipment on site to really help that baby, help that mother really effectively and quickly. Also, monitoring is much greater in the hospital. Mother and baby, they're going to be closely monitored by that medical professional team. Additionally, everything's really provided for you that you need. You have your meals, your medications, even toiletries like sanitary napkins, those are all provided. And really, there are specialized staff there as well, like lactation consultants who can help you with breastfeeding. You don't get that in other settings. But just like the other options, there are some cons that you have to consider. First of all, it's really hard to rest in a hospital setting. If any of you have been in the hospital before, you know what I mean. People are in and out constantly, even in the middle of the night. It's also not as homey feeling. It tends to be a more sterile environment, much harder typically to follow that natural birth plan. And unfortunately, a lot of those holistic options like a water birth, most hospitals do not allow those. It's important to have an advocate. Again, you're going to have a lot of people coming out making decisions for you, and you want someone there who can advocate for you because you're going to be in pain focusing on delivering your baby. Additionally, if it's a teaching hospital, very possible you're going to have a lot of students coming in and out. They should be asking permission, but they don't always. And then, really, one of the number one concerns with the hospital setting is there's increased risk of exposure to infectious disease. So, that's one of the main reasons people do tend to avoid that hospital setting. All right, I'm going to pause real quick. We always get questions about that SurePass combo. What package should I get if I decide to go with Archer? And really, our number one product is SurePass. So something to look into if you're studying for your NCLEX, if you need help, this is going to get you where you need to be. And it includes a lot. It includes all of our on-demand videos, which are wonderful. We have dozens of those. But something that's actually not listed here is it also includes the live lectures. I'm actually one of the live lecturers. I lecture for 3 hours every Tuesday. Lexi Garber is our lecturer for Thursdays, and you get robust presentations every Tuesday and Thursday. In addition to that, you get live case studies every Monday, Wednesday, and Friday. So every day of the week, you could be watching a live lecture. We also have an excellent Q bank. There are tests within the Q bank that actually analyze your readiness, should you take the NCLEX or not. And then my favorite, we have the 3-day live review. You get a one-time admittance to that live review, 3 days jam-packed with information that's likely to show up on the NCLEX, and it really rapidly prepares you to test. So no pressure, but something to look into, again, if you're studying for your NCLEX. But now that we've talked about the different locations you could deliver at, we got to talk about some of the delivery methods that might be used. And of course, the one we're most familiar with usually is just the good old-fashioned vaginal delivery. This, of course, is where the baby is born through that vaginal canal, which we also call the birth canal in labor and delivery. And most women are going to give birth, of course, at that full term due date of 40 weeks, somewhere around there. So typically, most women give birth about 39 to 41 weeks. And it's really what's most recommended. We want our women to be delivering vaginally because there's a lot fewer risks. And as you can see, there are a lot of benefits. You're going to be in the hospital less if you deliver vaginally, much less likely to get an infection. You recover much faster compared to C-section. And then really baby has fewer risks as well, much lower risk of respiratory issues when that baby is born vaginally. So that is the way to go. If we can safely deliver vaginally, we should do that. But we can't always safely deliver vaginally. There are going to be some situations where a C-section is much more of a better option. And basically, this is a delivery where the baby is delivered, and it's going to be completed by making a surgical incision in that lower abdomen, and it cuts right through the abdominal tissue, right through the uterus where the baby is housed, of course. And this could be scheduled in advance. Some people do opt to do a C-section for a variety of reasons, but often this is actually done in response to an unforeseen complication. For example, if the mother is having a complication, like she's hemorrhaging all of a sudden, we're not going to waste time. We're going to take her emergently for a C-section in the OR. And as you can see, there are a lot of reasons we're going to do a C-section. If you have multiples, twins or triplets, it's typically much easier, often safer to deliver them via C-section. Or if you just have one baby that's really big, a macrosomic baby over 9 pounds, often they can't fit through the birth canal, actually, or at least they can't safely do that. So we would potentially deliver them via C-section as well. Certainly, if a woman had prior C-sections or she had a uterine condition that prevented her from having a vaginal delivery, we could do a C-section. If the fetus is in the wrong position, if baby is breech, which is when their butt is down first, or if they're transverse in that sideways position, we can't safely deliver them vaginally. We're going to do a C-section. Placenta previa is a big reason. And then if there's any obstruction like a fibroid, a C-section would be indicated as well. But ultimately, like I said, vaginal delivery is the option we're going to opt for because a C-section is really a major surgery. It requires longer recovery times. So it should only be done if it's medically indicated. You shouldn't just decide all of a sudden that you're going to have a C-section. Now, there's a couple more things you want to know about a C-section. There's actually two different ways to perform it. You can do it as a low transverse or horizontal incision, or you can do a vertical classical incision. And really nowadays, we always use the low transverse incision unless there's a very specific reason, because it's much, much safer. And basically that low horizontal incision is going to make a cut across that lower, thinner part of the uterus. And the reason for that is important. Those muscles in the lower portion of the uterus, those don't contract as strongly as those upper muscles in the uterus. And therefore, if you make an incision there, the uterus is much, much less likely to rupture during a subsequent labor and delivery. So it's much, much safer. And that's why this is the usual practice for OBGYNs really since the 1970s. And the rupture risk is very low. It's about 0.5 to 0.9% per birth. Now, on the other hand, the way we used to do it way back in the day is that classical vertical incision. And that, of course, is going to be a vertical cut. It comes with more risks, unfortunately. Basically, this incision is going to cut down through the muscles way at the top of the uterus, and those muscles contract much more strongly during labor. And therefore, the uterus is much more likely to rupture during a subsequent labor. And the risk is even higher if the incision is higher in the uterus. So again, that's why that low transverse incision so much better. Now, like I said, we almost never use this type of method. We try to go low transverse, but if the uterus has really dense scarring, if there are adhesions, if the client is morbidly obese, then we might consider doing this. But you can see, look at the difference in the rupture risk. With a low transverse incision, it's less than 1%. With a vertical incision, it's 4 to 9%. So you can see why we've changed our methodology there. Now, some people do a vaginal delivery after a C-section, and that has some special things you need to know as well. VBAC is what it's called. That stands for vaginal birth after C-section. And do know this is kind of a recent practice. Back in the day, if a woman had a C-section, she really was not able to do a vaginal birth in the future because we were doing those vertical incisions and the rupture risk was just too high. But now we're doing those horizontal low transverse incisions, and we do them all the time. In fact, it's actually estimated that about 75% of women who try VBAC, they go on to have a successful vaginal delivery. It's not for everyone, though. Some conditions are absolutely going to remove the possibility. Again, if there's something like a placenta previa, we can't do a vaginal delivery. And in fact, tell me in the chat, guys, those of you active in the chat, why do you think we could not do a vaginal delivery if there's a placenta previa? What's the deal there? Tell me what you remember. Blocks the cervix. That's what I was looking for. Exactly. Remember, placenta previa is where the cervix, which opens into the vaginal canal, that placenta is covering it. And if you try to proceed with a vaginal delivery, it's going to cause trauma to that placenta. Yeah, the placenta is going to rupture and bleed. way too high risk. So certain things we wouldn't even consider. Now, do know not all hospitals are going to offer the option of VBAC. If you have a smaller hospital, they're not going to offer it. There's not enough staff. There's not enough resources to perform an emergency C-section if the VBAC fails. And do know there's a big risk with this. You got to be aware of. You've got to tell your client there is a risk of uterine rupture. And that's basically, it's awful. It's where the fetus gets expelled into the abdominal cavity, the peritoneum, after that uterine ruptures open. And of course, not good. That's going to cause massive bleeding. Both mother and baby could bleed out very, very quickly. So, it's rare. Uterine rupture is rare, but it's a serious enough risk that you've definitely got to have a conversation with the mother. Now, if you decide to have a vaginal delivery, and of course, most of the time women should try to do a vaginal delivery, there's a couple extra techniques we might use with that vaginal delivery. And the first one is a vacuum delivery. This is basically a procedure that's used to assist with the vaginal childbirth. And basically, the provider is going to attach a suction to the baby's head. It's basically like a soft cup with a handle on it. And then you have a vacuum pump that provides suction, and you put that on the baby's head, you suction that on, and then you just gently pull. You use gentle traction, and that can help guide baby out of the birth canal. And yes, it can cause a little bit more of that cone-shaped head. It can cause a little trauma to the head as well. And we'll talk about that more when we get to forceps deliveries. But yeah, you can get bruising. You can even get skull fractures and brain damage. So we only use this if it's absolutely necessary. Now, similar to a vacuum delivery is going to be a forceps delivery. And this is where a forceps is basically applied to the baby's head. And I always describe it, it's kind of like a big salad tongs is what it looks like. And you just apply that to the either side of the baby's head, and you're going to use it to gently guide the head through the birth canal. Now, of course, you got to be really gentle. Otherwise, again, it can cause trauma. You can get bruising, facial palsies, and like I said, brain damage, cerebral palsy are possibilities as well. Now, in my experience, most providers, especially if it's closer to that full term due date, most providers prefer the vacuum. There tends to be less injury with that, but it depends on where they're at. For example, if the woman is delivering prior to 36 weeks, forceps tend to cause less injury, so we're going to use those. But if it's after that 36 weeks, again, most providers do opt to use that vacuum. Oh, someone just asked a great question. So, hey, if there's all this risk, if it can cause skull fractures, bruising, brain damage, why are we even trying it? Why don't we just do a C-section? Well, the risks are still probably less than C-section. We know with C-sections, they prolong hospital stays. There's greater risk for infections in both mother and baby. It decreases bonding time. There are all kinds of downsides to C-section. So we still want to try to do a vaginal delivery with possible, even if we have to use that assistive device. Very good question. Now I got to pause again real quick. I was seeing some questions about tutoring as well. And there's a couple different ways to do tutoring at Archer if you feel like you need that to help you to prepare for the NCLEX. One of the less expensive ways to do tutoring is our small group tutoring. Just $25 an hour, really, really good deal. And really the focus is going to be on practice questions, and it's going to go over very specific content that you need to pass your exam. For example, I do small group tutoring. I do the different test plan areas. So for example, if you failed your last test and you're like, whoa, I was below the passing standard on basic care and comfort, I got a small group for that. We can help you work through that. Or Lauren, for example, Lauren Kors, she's our pharmacology expert. If you're anything like I was in nursing school, that was my biggest issue. We have people who are experts in a variety of different topics that can really help you. So feel free to scan that QR code if you're interested. But next, we've talked about where you deliver. We've talked about the different delivery methods. Next, we have to talk about the signs and symptoms of labor. You're usually the person that the client is going to talk to when they're experiencing these symptoms. So you got to know how to recognize if someone's really in labor. But real quick, I just have to give a quick shout out to Regina. Regina just let us know that she took her NCLEX last Monday and she passed in 85 questions. And I know Regina attended a lot of the lectures that I was at, and you deserve this outcome. You worked hard, and we're really proud of you, Regina. So I just have to say a quick congratulations. So, again, what are those signs and symptoms of labor? Well, first of all, contractions are a really big sign, but there's really two different types of contractions. There's true labor contractions, and then there are kind of the pretend false labor contractions, and we call those Braxton Hicks contractions. Now, let's go ahead and compare them really quick. So, first of all, if someone is truly in labor, they're going to have regular contractions. You could take a stopwatch and you could time between the contractions, and it's going to be very regular. But those contractions are going to get closer and closer and closer together. That is one of the big clues that you know it's real labor. On the other hand, if it's false labor, those contractions are going to be all over the place. If you tried to time it with a stopwatch, you'd be getting random numbers all over the place. It's not regular. Now, with true labor, it doesn't matter what mom does, the contractions are going to continue. You cannot stop labor contractions if you're actually in labor. At least you can't without certain treatments and medications. But if it's false labor, you can make them go away if you get up and walk or rest or change positions. Something I would always tell my clients to do to try to determine if it was real labor or not, I would say, I want you to do three things. I want you to go pee, empty your bladder. I want you to drink a tall glass of water, hydrate, and I want you to put your feet up and rest for 15 minutes. If they continue after you do that, it's probably real labor. If they don't continue after that, it was probably just those Braxton Hicks. Now, with true labor, the intensity is going to get worse and worse and worse. So when you start out, you almost kind of think, oh, this isn't so bad. I can handle it. But it's going to get continually intense. And eventually, most women get to a point with their contractions where they can barely talk through the pain. It's very, very intense. But on the other hand, if it's false labor, it's not going to be that bad. It's weak, it's irregular, you can function through it. And then finally, where the pain happens indicates if it's true labor or not. If it's true labor, actually the contractions are going to start in that lower back area and they're going to extend towards the front of the abdomen. But if it's false labor, mostly you just feel weak contractions in the front. So that's a big clue as well. But what I always told my clients was the 5-1-1 rule. Basically, if a woman is in true labor and she needs to go to the hospital, she's going to be having contractions every 5 minutes, lasting for a minute each. And that happens over the course of an hour. So if a woman is having contractions every 5 minutes lasting for a minute, that's it. I know she's likely in labor. She needs to go to the hospital or wherever she's going to deliver. Real quick, I have to give a big shout out to Anab as well. Thanks so much for letting me know you passed. Anab was one of our attendees at the live lectures as well. And Anab passed in 85 questions also. So I'm very happy for you. Very, very good job. All right, we're proud of you. Now, there are other ways to tell if someone is in labor as well. If that amniotic sac ruptures, that's a pretty big clue. So, this can occur while a woman is actively in labor. So, if she's already contracting, that bag of waters can definitely break. But sometimes the rupture happens first and then contractions follow after that. Now, just so you guys know, when you're watching someone on TV who's in labor, they always make it look so dramatic. It's that big gush of fluid that's released. That actually doesn't happen very often. About 90% of the time, it's going to be more of a steady trickle of fluids. It's not a big gush. You can almost feel and hear that pop of the amniotic sac rupturing. And then it's a steady tinkle, tinkle, tinkle. If you were sitting on a toilet, you would just hear a steady trickling. Now, there are some terms that you need to know, and these especially do seem to be tested on a lot on the NCLEX. So I'm going to underline these. I want you to pay extra attention to these. So first of all, we have PROM. That stands for premature rupture of membranes. Now, PROM can happen anytime during the pregnancy. It could happen at 40 weeks. All that means is that the amniotic sac ruptured before contraction started. Now, tell me, guys, I have a question for you. I want you to answer in the chat. How can you tell accurately if the amniotic sac ruptured? How do you test that amniotic fluid? Does anyone know? There's a special test. Tell me in the chat. Good. I'm seeing a bunch of you are getting this. Yes, the nitrazine test. It's a little pH paper. You just dip it in the fluid. If it turns what color, we know it's amniotic fluid. What color? Blue. Yeah, that tells us it has a very high pH. So that nitrazine test is really the gold standard. That being said, the provider can also look at the amniotic fluid under the microscope, and it presents as ferning, is what it's called. It's a very distinct appearance. And I got to tell you guys, both me and Jennifer, when we worked in the office, that was our favorite thing to look at under the microscope. Ferning looks so neat. Okay, next we have PPROM. That stands for preterm premature rupture of membranes. So that's a little bit different than PROM. Pre-PROM means that the bag of waters broke prematurely. It broke before 37 weeks. And remember, 37 weeks is a very important gestational date in pregnancy. Tell me in the chat one more time, guys. Why does 37 weeks, why is that so important? That term due date. Yes, you guys are getting it exactly. It's not until 37 weeks that all of the organs are fully developed, especially the lungs. So as you can imagine, if someone has pre-prom, that preterm premature rupture of membranes, we don't really like that. That's before the lungs have developed. We don't want them going into labor yet. And actually, this causes about a third of all preterm births. And usually it's because there's some sort of infection in the uterus, usually something like chlamydia or gonorrhea. We also know that women of lower socioeconomic status are more likely to have this happen. Smoking cigarettes increases the risk for this. But again, we don't like seeing this because it can lead to uterine and newborn infections, which can be very problematic, of course. Finally, we have AROM. That's the artificial rupture of membranes. And we also just call that an amniotomy. And sometimes in the office, we would just call that the breaking of the water. And basically, that's when the provider, someone like Jennifer, a midwife, actually intentionally ruptures those membranes to induce labor. And this has been done by OB providers for hundreds of years. Basically, we use something called an amni hook. It kind of just looks like a crochet hook. And we actually just hook right onto that membrane and give it a tug. that artificially ruptures the membrane, and that can actually help to induce labor. So sometimes we'll do that depending on the clinical status of baby and mother. Now, there are a few other signs that someone is in labor, but these are much less specific. You don't count on these as much as you count on the contractions and that breaking of the water. But bloody show, that's definitely a big one. If there's a small amount of blood at that cervix, that really tells us that the cervix is changing. It's starting to dilate, it's starting to thin down, and that can lead to a little bit of bleeding. So that often happens before someone's about to go into labor. That being said, you do want to educate the client. Now, a little bit of blood is kind of expected before labor. Large amount of bleeding definitely not expected. So we definitely need to educate mom and family that if the bleeding is heavy, they need to go straight to the emergency department, of course. Mucus plug, that's not specific at all. That's just a clue that you might be going into labor in the next couple weeks. Basically, when that cervix, remember the cervix is the bottom of the uterus, that's kind of what holds baby in the uterus, that cervix. During pregnancy, that cervix should be long and firm and closed. It holds baby in place. And inside that cervix is a mucus plug. Now, before labor, of course, that cervix has to dilate and thin down, and that's going to cause the release of that mucus plug. So if you see that, it means that labor might happen in the next couple weeks. Back pain is actually a fairly good indicator, especially if it's in that lower back and it's happening rhythmically. It starts in that lower back and kind of radiates into the abdominal space. And again, if that's happening regularly, you can time it and it's getting more intense. Probably they are actually in true labor. And then finally, nausea and vomiting are pretty common in labor and delivery as well. And that's really because of the hormonal changes. So that's not as specific, but it's definitely something we watch for. But ultimately, it is up to the provider to decide if the client's in labor. And really, the gold standard is if you're doing those cervical checks and those contractions are leading to cervical dilation and cervical changes, that's when you know the client is actually in true labor. Now, of course, to know if that cervix is changing, you have to know how to assess those cervical changes. You need to assess, is that cervix dilating? Is it opening up to be able to allow that baby into the birth canal? And is that cervix thinning out as well? And we actually measure these things just with our fingers. It's something that takes a while to really become an expert at. But for dilation, of course, it has to go all the way from a closed cervix to 10 centimeters. It has to be able to fit that baby's head through that cervical opening. So that's a pretty a big change, of course. And the way you measure that is you actually do what's called a cervical check. You insert 2 fingers into the vaginal canal. You feel for that cervix and you insert your 2 fingers into that cervix. And you basically spread your fingers. And then what I would do, I always had a ruler handy. After I did that, I would hold my fingers up to the ruler, and that would help me to determine how dilated that client was. Effacement, you actually use your fingers as well. Again, as that cervix dilates, it's going to thin out. And this is measured in percentages with the help of your index finger. What you're going to do is you're going to insert your index finger into that cervix. Now, if you can insert your finger deeply into the cervix to that second knuckle, that cervix is not effaced at all. It is fully thick. We would call that 0% effaced. Nothing has happened yet. Now, on the other hand, if you insert your finger and you get to that first knuckle, it's about 50% effaced. You're about halfway there. And then finally, if you try to insert your finger and you can only fit that little fingertip in, 100% effaced. Action's about to happen pretty soon. You better get ready. Okay, finally, I have a Slido for you guys. Let's do it. So this question says, a prima gravida client at 38 weeks arrives at the hospital maternity triage unit reporting a sudden gush of clear fluid from her vagina shortly before arrival. The maternity triage nurse suspects the client has experienced a premature rupture of membranes. Which of the following is the most appropriate method for the nurse to use to confirm her suspicion? So we just talked about this. I know a lot of you guys know it. Go ahead. Either you can answer in Slido or you can answer in the chat. Or if you're following on Facebook or YouTube, feel free to put your answer in the chat, in the comments. Oh, you guys are good. Exactly. If we, as the nurse, we're going to test that fluid, really the gold standard is going to be that nitrazine paper test. So 92% of you guys got that. Very, very good job. And of course, remember the provider could also take a sample of that fluid to look at under the microscope. And we would be looking for that ferning, which is very, very cool to see. Of course, the provider should also be doing a vaginal examination, but that's not the gold standard. The nitrazine test is much more effective. Ultrasound isn't going to show us what we need, nor is a gram stain. We do that to rule out infections. And then HCG levels, pregnancy hormone levels, those aren't necessarily going to change if the bag waters has ruptured. So very good job, you guys. Okay, I have another Slido for you guys, though. Let's get ready. Tell me which of the following are symptoms of true labor. And do know, guys, this is a select all that applies, so it's a tricky one. You can answer in the chat or Slido or in the comments if you're online. No, the Fern test is a test you do under the microscope. It's where you actually visualize the amniotic fluid under the microscope. It has a very distinct ferning appearance. It what we call is ferning, and it has a very distinct appearance. The nitrazine test, on the other hand, is just a pH strip that tests the acidity of the fluid. So very, very different things. Okay, you guys are doing really well in the chat. And it looks like a lot of you guys got it as well in Slido, but we did have quite a few people who chose this option as well. So absolutely, contractions that are regular in intervals, that's more likely to be true labor. And again, that lower back pain is very common as well. On the other hand, contractions that are consistent in intensity, not that one. It sounds right. But remember, if someone's in true labor, the contractions are going to become increasingly intense. They don't stay consistent. Yeah, they get stronger and stronger and stronger. Now, contractions that are localized to the lower abdomen, that's more likely to be false labor. And again, contractions that go away when you walk or do something to stop them, that's also not true labor. Very good job again. All right. So earlier we had talked a little bit about small group tutoring. Definitely a great option, very cost effective. But if you need more of that one-on-one tutoring, you need someone to really work through your work as an individual. Private tutoring is really the way to go. It is $75 per hour. You get a full hour and you can do whatever you need with your tutor. They are excellent. I do a little bit of private tutoring, but as you can see, we have a ton of different expert tutors who all have their different specialties. But do know all of our tutors can prep you for the NCLEX in a variety of ways. They can create customized study plans. That's one of my favorite things. We can go over, if you have a Q bank in Archer, we can actually go into your profile and we can figure out where your weaknesses are. And we can tell you, of course, how to improve those. And of course, if you have a really specific area of content that you're struggling in, let us know. We can cover that as well. Really, whatever you need, we tailor the appointment to you. So I really like private tutoring as well. Okay, and we have another Slido. We're hitting you hard with the questions, but they're good to do. So this one says, a client presents to the obstetrics floor at 39 weeks gestation with irregular contractions. After you get the client situated in the labor and delivery room, you notice that the client's healthcare provider enters the room to evaluate the client. Following the evaluation, the healthcare provider exits the room, and shortly thereafter, you enter. During your discussion, the client states that the healthcare provider went to order oxytocin. In anticipation of that order, you understand this client's oxytocin will be administered via which route of administration? They like to ask about this on the NCLEX. This is kind of a tricky one. So how do we give oxytocin? What do you think? Good. I'm seeing a lot of you in the chat do know this, which is very impressive. Excellent. Let's go ahead and take a peek. 72%, 71 of you guys got this. And I noticed a lot of you guys were getting this right in the chat as well. Absolutely. We want to do that IV administration via piggyback using an infusion pump. Of course, that infusion pump is going to allow us to more accurately administer very specific amounts of that oxytocin. Now, tell me, guys, why do we give oxytocin? Remind me, you got to know this for sure. Why do we even give oxytocin? Yes, it's what we call an oxytonic. It's a class of med called an oxytonic, and it's going to stimulate contractions. It's going to make them stronger and faster. And just like you guys say, we use that a lot to induce labor, but we want it as a piggyback infusion because if there are complications during labor, we need to be able to turn it off much faster than you could with a lot of these other options. Very good. Now, of course, before someone goes into labor, we need to know where that baby is in the birth canal. And we actually call that the station. How far down is the baby in that birth canal? And that kind of helps us to predict when labor is going to happen. Now, first of all, you need to find zero station. Zero station is actually where that ischial spine is in the pelvis. It's the most narrow point of the pelvis. So you insert two fingers, you feel for that first, and then you determine, is baby above or below that point? Now, if the baby is above zero station, that's a negative station, -1, 2, or 3. That means it's probably going to be a little while until baby's delivered. But if baby has a positive station, +1, 2, or 3, you better get ready for labor because baby's going to be coming sooner than later. So you need to know how to measure that as well. And that's what brings us to the stages of labor. Now, this is something that very commonly is going to come up on the NCLEX. So I really want you to pay close attention to this. And do know there are actually 4 stages of labor. And we're going to start with the first stage, of course. So the first stage is when labor starts. It's when contractions begin to cause cervical changes and dilation. And it ends when when the cervix is fully dilated to 10 centimeters. So basically, the first stage is all about getting ready for the baby to be delivered. That's stage 2. Now, this can further be divided into 3 phases: latent, active, and transition. Now, some resources only list latent and active, but most use the 3. So, with latent, first of all, that's when things are kind of changing slowly. That's when the cervix dilates from 0 to 3 centimeters. And like I said, it's slow, it's less predictable. That's usually where the client can just kind of stay home and labor at home for a little bit. But once they transition into that active phase of labor, that's much more predictable. Things are going to speed up quite a bit. And that's where the cervix is dilating from about 4 to 7 centimeters. They should be coming to the hospital at that point if that's where they're delivering. And then finally, we have the transition phase. That means they're going to start pushing soon. That's where the dilation occurs from about 8 to 10 centimeters, and that fetus is really getting into position in the pelvis. Do know if there's any lack of cervical dilation for 4 hours or more, we call that an arrest of labor. And typically, that's the point where the provider is going to have a talk with the family, the mother, about, do we want to augment labor with an oxytocic? Do we need to switch to a C-section? That sort of thing. That, of course, brings us to the second stage of labor. And this again begins when that cervix is fully dilated, and it's going to end when baby is fully delivered. Now, there is an important part here, the 7 cardinal movements. Those 7 cardinal movements are basically how that fetus is going to pass through the birth canal. And real quick, I want to talk through those with you really quick. So it starts with what we call engagement. Engagement is where that baby's head is at 0 station. So remember, 0 station is that most narrow point of the pelvis. Once baby's head is there, that is engagement, ready to go, ready to start pushing. Next, we have descent and flexion, and those actually happen at the exact same time. Descent is the movement of the baby's head through that bony part of the pelvis, through those ischial spines. And flexion is where the baby's head aligns the chin towards the chest. And the reason for that, baby kind of tucks their head in, and that's going to prevent any facial trauma during delivery. Next, we have what's called internal rotation. This is where baby's kind of like a wiggle worm. I like to say baby's going to rotate head from side to side, front to back, and going to start to navigate through the pelvis. Then there's extension. That's where the baby's head, face, and chin is delivered, extending out of the vaginal canal. Next, we have external rotation. That's where the baby's head starts facing down. This is the face down, and baby's head is going to rotate a full 90 degrees towards one of the mother's thighs. And then finally, we have expulsion. That's where the baby's body follows the head. The rest of the baby is delivered. So do be somewhat familiar with those. But of course, the second stage is really the pushing stage, and it typically lasts for about 3 hours for women who are nulliparous and about 2 hours for multiparous women. But do know, if you have an epidural, it could take a little bit longer. So that is one of the downsides of an epidural. But there's actually multiple elements that determine how long this stage takes. How big the baby is, what the position the baby is in, maternal pelvis shape, pushing ability of the mother, and a variety of other factors like chronic health issues, prior deliveries. So a lot of factors play into this. Next, we have the third stage, and this begins when baby's fully delivered, and it ends when the placenta has been delivered. So really, the third stage is all about delivering that placenta. Now, the separation of the placenta from the uterine wall typically has three distinct signs. There's going to be a gush of blood from the vagina. That's the placenta detaching from the wall. There's a lengthening of the umbilical cord. There's going to be more slack as that placenta detaches. And then the uterus becomes globular shaped. It becomes more rounded when you press at the top, when you palpate. And typically, the placenta should be delivered in about 5 to 10 minutes. But do know if that placenta takes longer than 30 minutes, that increases risks, especially for that postpartum hemorrhage. You've got to watch that client more closely in that fourth stage of labor. And the provider might assist with the placental delivery. The provider can kind of gently pull on the umbilical cord, and they can also apply fundal massage. But do know sometimes, and this is kind of alarming the first time you see it, but sometimes the provider might reach their entire arm basically up into the uterus to remove the placenta. And they might also use their hand to scrape out clots and blood from the uterus as well. So, first time you see it, it's alarming, but it actually is a helpful thing. Finally, we have the fourth stage of labor. And this is after all of the delivery has happened. Baby's delivered, placenta's delivered. And this is usually the busiest time for the nurse if you work in labor and delivery. And really, it accounts for that 1 to 2 hours after delivery. Now, the provider is also going to be busy during this time. Typically, they're repairing lacerations or tears that have occurred. But really, the nurse has a lot to do between mom and baby. The nurse is going to monitor mother closely, especially for signs of hemorrhage and infection, and also uterine atony. Now, real quick in the chat again, tell me, guys, what is uterine atony? What are we watching for? What is that? Good. Very good, Sumitra. Yes, I'm seeing a lot of you saying it. Exactly. Uterine atony is when that uterus is boggy. It's just sitting there, it's not contracting. Remember, exactly, we want that uterus to be contracting, clamping down on those bleeding vessels inside the uterus, and that's going to help prevent a hemorrhage postpartum. Simultaneously, though, I mean, the nurse, of course, has to keep a really close eye on mom, but at the same time, they've got to monitor baby as well. They're doing preliminary assessments and treatments for baby. So again, that first 1 to 2 hours after delivery, it's a little hectic for the nurse. And I have another Slido for you guys. I love doing these. This one says the nurse is taking care of a client in the fourth stage of labor. She notes that her fundus is firm, but she is still bleeding profusely. What should be the nurse's first action? I really like this question. It's quite challenging. This one's tricky. I'm going to warn you. Really pay attention to all pieces of this question. Good guesses. All right, let's see what you guys are thinking in Slido. Yeah, I noticed it was a pretty even in this split in the chat as well. But this is one of those occasions you have got to call the provider. This is actually a medical emergency. And it says why in the question. The client is bleeding profusely. Your client is hemorrhaging. We don't handle a hemorrhage alone. That's a medical emergency. We need to act on that fast. But the other thing it told you is the uterus is firm. Is massage going to help if the uterus is already firm? What do you guys think? No, no. So it's probably not uterine atony that's causing this bleeding. It's more likely it's actually a uterine laceration. There's a cut somewhere. There's something else that's going on that's causing that bleed. And hey, we're not surgeons. We cannot fix a laceration on our own. We've got to call the surgeon. They've got to go to the OR emergently. But I agree with you guys. If this had said that the uterus is boggy and that they were bleeding maybe a little bit more than expected, that's when I would massage the fundus. But with this clinical scenario, we really got to get that provider involved. And you guys made it. We did it with a minute to spare. So I just have to say, thanks so much for joining, guys. You were a wonderful audience, as always. Thanks for answering all my random questions. You guys did very well with that. And just know that we really do care at Archer. We really will do whatever we can to help you guys pass your NCLEX and become proficient nurses. So thank you so much for allowing us to help you with that process. And again, congratulations to those of you who joined to let us know you passed. That's always wonderful. That makes our day when you guys post those. So thanks for sharing. Thank you. You guys were wonderful. I hope you have a great rest of your day. And I hope you're able to join us for more of these webinars. We typically do them about every Monday, Wednesday, and Friday most weeks. So keep attending these. We love having you. All right. Take care. Thanks again.